Good afternoon, everyone. I am Teresa Tull. I'm the American Pharmacists Association President for 2022-23 and excited to be here hosting our webinar today. Certainly an exciting topic. It's not exactly what we thought we had planned for this month, but we were able to make a change when we saw this announcement come out from the FDA last week. So our focus today will be discussing the prescribing of Paxlovid by pharmacists and services that pharmacists will provide and the conditions under which pharmacists can order and prescribe Paxlovid. So excited to have this as our conversation for today. So I'd like to introduce to you our speakers for today. First, we have Dr. Florin Drajka. He's the U.S. Senior Medical Director of HQ Team Lead Anti-Infectives, North America Medical Affairs, Pfizer Hospital. Florin leads the U.S. HQ Anti-Infectives Medical Team and U.S. Medical Affairs strategies and responsibilities for Paxlovid. He's got 20 years of pharma experience in country, regional, and global roles. After leading a digital health startup, Florin joined Pfizer in 2008 to lead operations for the respiratory and later the CV portfolio before moving to regional roles in pain, CNS, WH, MH, and ophthalmology in Europe. Since 2015 in the US, where he had roles in medical excellence, medical innovation, and medical digital, and previously to the current role, Florin was the Senior Medical Director for the hospital portfolio. Welcome, Florin. And next we have Dr. Shalita Dattani. She's the Vice President of Pharmacy Affairs at the Neighborhood Pharmacy Association of Canada. And in this role, she leads a team advocating for pharmacy's evidence-based role in delivering accessible, high-quality healthcare and building capacity in public health and primary care. Shelley brings over 20 years experience in many sectors of the profession, including community, hospital, academia, industry, group purchasing organizations, and pharmacy associations. She completed her Bachelor of Science degree in pharmacy at Northeastern University and her Doctor of Pharmacy at University of North Carolina, Chapel Hill. Shelley maintains a practice in community pharmacy and primary care team-based practice. And also joining us today is Dr. Megan Panini. She is the Director of Therapeutics for the HHS Office of the Assistant Secretary for Preparedness and Response, and we call that ASPR. So again, welcome to all of our speakers, our guest speakers. And then we also have our own team from APhA. And first is Elisa Bernstein. She is the Interim Vice President and CEO of the American Pharmacists Association. And we also have Michael Baxter. He's the Senior Director of Policy for the American Pharmacists Association. So our format for today's webinar is that we're going to have our panelist discussion first. We're going to do questions and answers. And then we will also do some opportunities near the end for you to input questions for our panelists to respond to. And then finally, we're going to ask you to take action. So we have some opportunities for you to respond and reach out and provide some advocacy. And that's the whole reason for this Pulse on Practice and Policy series. So our ground rules are that you will use the questions field in the GoToWebinar toolbar to submit questions. We don't have any opportunities to raise your hand or ask questions, so you'll submit them that way. Our goal is to get to as many as possible, and we have a great team behind the scenes that's working very hard to do that for us. And then in the toolbar, there is a handout for additional resources. And this webinar is being recorded today so that we will have it available to our members afterwards. So I do just want to point out our antitrust statement that is on the screen at this time. I'm not going to read it, but I want to make sure that each of you know that if there's anything that brings any concern today, if you will just be sure and put a comment in, then we will be sure to address and possibly stop that discussion if there's any concern. So please let us know. So with that, we are going to start off with Elisa Bernstein to talk to us today about how we got here. She's going to share our advocacy efforts from the American Pharmacists Association and just all the background material of how we've arrived at this point for pharmacists to be able to prescribe Paxlovid. So Elisa, go ahead and kick us off.
Thanks, Teresa, and thank you all for being here with us today. This is going to be a great hour. There's a lot to talk about, so I'm going to try and wrap this up in a little nutshell to give you the background of how we got to here. So if you are a pharmacist by now, you have probably heard of the PrEP Act, the Public Readiness and Emergency Preparedness Act, which has given pharmacists the authority through HHS to test, immunize, and prescribe across the country, regardless of what state law is, in a preemptive way. And in 2021, HHS, as part of that authority, authorized pharmacists to prescribe oral COVID therapeutics. And that had to be in conjunction with what the conditions for use are for whatever those oral COVID therapeutics are. So in December of last year, FDA authorized Paxlovid and another oral COVID therapeutic, and specifically in the conditions for use, they limited who can prescribe, and pharmacists were not included in the labeling or in that EUA for as prescribers, only physicians and advanced practice nurses. So almost immediately after we realized that pharmacists were not included, even though HHS had laid the groundwork for pharmacists to prescribe, we reached out to FDA, to HHS, all over saying, what's up with that? We can do this. HHS said we can do it. Why are we not included as prescribers, which was actually unique in FDA not including specific, or not actually including specific prescribers. So we spent a lot of time providing FDA with information to give them the comfort and confidence that pharmacists can do this. The president in March announced the Test to Treat program, which was a program where you can go to a pharmacy as a one-stop shop, get tested, and get the oral therapeutics prescribed, but those were a very limited amount of pharmacies, and those were only those that had an already authorized prescriber. There was a problem though, and we at APhA did an analysis that showed that those Test to Treat pharmacies were in areas where they were least needed, and that in medically underserved areas of the community, in those of the country that had a high social vulnerability, did not have Test to Treat locations. CDC, after we came out with our study and data, CDC confirmed our analysis. We shared that with the administration, continued our advocacy, and in June, just recently, the FDA did modify and amend the EUA and added pharmacists as prescribers with certain conditions. So that was the nutshell, getting you up from where we are and today. And I know that I'm gonna turn it back over to you so that we can talk more about what those conditions are and more about the experiences. Thanks.
Thank you, Elisa. And I am so proud of all the work that APhA and our advocacy team has done behind the scenes. I especially love those slides and how we showed that patients who had the highest need weren't having access. And I know that's what made the difference. So I'm super excited that we've done this work, and looking forward to where we go from here and how we get to showcase what pharmacists can do. I will just talk briefly about my experience. So I do own an independent community pharmacy in Florida. We are in an area of moderate social vulnerability, and also considered a health practitioner shortage area. So our pharmacy did enroll. We were able to, through our FRPP, we were able to enroll in the Test to Treat program back in March. We did get a relatively slow start with dispensing of the oral antivirals, and we've only had Paxlovid actually, just because a few different things. I think one, prescribers were a little concerned about side effects and drug interactions and who qualified. So we were trying to do our best to make sure that we were educating. And also, I think many times, like, it was a little bit late for patients to get it, but we actually did have some prescribers turn patients down. We've had one experience where we had a 67-year-old patient who had a couple of chronic conditions, including obesity and diabetes, and was on day 2 of their symptoms and tested positive, and the doctor didn't want to prescribe for them. So there's been a few situations like that. We've also had the opposite, where we've had prescriptions sent to us for a 27-year-old with a heavy menstrual flow, but that was the only qualifying condition. So of course she didn't qualify. So we're very optimistic about the opportunity to really impact patients more, and not have so many hoops that we have to jump through. Clearly we're going to learn more today about what we need to be doing as pharmacists, the data we need to be gathering, and how we need to do this in the appropriate way. But I do definitely think that this is going to open the opportunity for us. So looking forward to hearing this discussion today from Dr. Dryka and also Shelley Datani about their experiences in helping educate us. So with that, I'm going to ask our panelists to please turn their cameras on and join us, so I can start the questions. And Florin, I'm going to start with you. So can you describe the change that FDA did make to Paxlovid's EUA?
Yeah, thank you for the question. And first of all, thank you for the invitation to speak today. And I would like to thank every pharmacist and everyone for all the efforts, even up until now, because even before this change, we know that pharmacists were involved in patients getting the right medication and oftentimes conferring with physicians. So thank you for all of that. We welcome the expanded access and patients being able to treat early if they're at high risk for progression to severe illness. And actually, just to double down before I go into the changes on this area, this is a key area where oftentimes we see that patients who have one of those comorbidities or conditions that puts them at high risk for progression to severe illness are actually not aware that they are in a high risk category. People, for example, being diabetic, or people even with heart conditions, they are not really aware that they're a high risk for progression. And we know there's a distinction between high risk for progression to severe illness and symptoms, which can be moderate, but still patients are eligible, and treatment can be considered to prevent that progression. So moving on to the change in Paxlovid fact sheets, the new wording that was added, and the new information is that pharmacists Paxlovid can be prescribed by state licensed pharmacists with a few conditions, which are around having information about the health records, and that's very specifically in the fact sheet. So I encourage everyone to go and read the fact sheet. So sufficient information needs to be available through access to health records less than 12 months old, or in a consultation with a healthcare provider in an established provider-patient relationship with the individual patient to assess renal and hepatic function. And the same provision through access to health records for pharmacists to obtain a comprehensive list of medications prescribed or non-prescribed, so over the counter, that the patient is taking. The fact sheet further instructs that the state licensed pharmacist should refer an individual patient for a clinical evaluation with a physician, NP or PA licensed or authorized if any of conditions apply, and that is information to assess renal and hepatic function, sufficient information available to assess for a potential drug interaction, any modification of any other medications that are needed because of a concern for a drug interaction. And last but not least, if Paxlovid obviously is not appropriate based on the current authorized fact sheet. So in all these situations, the pharmacists are guided to refer for consultation. In addition, and I won't go over all the details, but in addition to the language in the fact sheet, FDA in their press release of this change have some wording, including guidance for patients to be to have those health records with them, either printed or in an electronic form.
All right, thank you so much for doing that and doing that overview. Can you talk a little bit about the efficacy that Paxlovid has had? You talked about disease progression. Can you tell us a little bit more about the efficacy that Paxlovid has had on progression of disease?
Yeah, absolutely. So first of all, just to ground on the authorization. So patients who can be treated with Paxlovid are patients who test positive for SARS-CoV-2 with a direct test or a PCR test, who have mild to moderate symptoms, and who are at high risk for progression to severe illness. And speaking of, so to your question, Teresa, on efficacy, so the data supporting Paxlovid emergency use authorization is based on the APhA trial, which stands for Evaluation of Protease Inhibition for COVID-19 in high-risk patients. This was a randomized phase 2-3 double-blind placebo-controlled study in non-hospitalized symptomatic patients over 18 years old with a confirmed SARS-CoV-2 diagnostic. The primary endpoint, so the primary efficacy endpoint, was the proportion of patients with COVID-19 related hospitalization or death from any cause through day 28. And just to highlight the results of that, and that's information also included in our in the Paxlovid fact sheet. Final analysis showed an 88% reduction in risk of COVID-19 related hospitalization or death from any cause compared to placebo in patients treated within 5 days of symptom onset. That number was 89% reduction in relative risk for hospitalization or death in patients who were treated in 3 days or less before following symptoms onset. To further on that, there were no deaths reported in patients who received nirmatrelvir ritonavir, so Paxlovid, and there were 12 deaths in patients who received placebo. And also, relative to placebo, Paxlovid treatment was associated with an approximately 0.9, so that's about 10-fold decline in viral, RNA levels in nasopharyngeal samples through day 5. And that was similar in different cohorts in the group. You asked about efficacy. I just want to add because we always think about the risk-benefit considerations. So just a couple of points on adverse events. Those occurred at similar rates in the Paxlovid and placebo arms of the trial. Serious adverse events were at 1.6% in the Paxlovid group and at 6.6% in the placebo group. And the proportion of patients who discontinued treatment due to an adverse event were 2% in the Paxlovid group and 4% in the placebo group, suggesting that disease, obviously symptoms were worse than otherwise. Thank you for the question. I'll pause there.
All right, sure, thank you. And just one other question for you, Florin, right now. I'm sure there will be many others. Can you talk to us a little bit about rebound COVID infections, there's been a phenomena we've heard of recently that called viral RNA rebound that we've seen a little bit. If you could explain that and maybe how prevalent it is.
Yeah, sure. I can speak about that. And thanks for the question. Indeed, this was a topic that received I think a lot of attention recently on the media. First of all, and you said it very well, Teresa, when you said viral RNA rebound, because actually this is what we measure. The concept is, I mean, that's my first message. The concept is still something that we and other groups are looking at how we define. And there's currently there are different notions that are involved and different ways to measure. So, for example, what you just said, what do we mean when we say viral load rebound? Does that need to be with symptoms? How persistent does it need to be to establish that? Is it infectious virus? That's probably the most important question. And the answer actually is suggested, and it's also in, this was part of a recent Paxlovid fact sheet update, where in the microbiology section, there was an update, kind of a subsection on viral RNA rebound. And I can comment that post-treatment, we've seen RNA shedding levels, so RNA rebound in nasopharyngeal samples that were collected, part of that same trial I was describing, APhA, and measured at day 10 or day 14. We've seen that the percentages were quite low, so around 2%. They were similar among Paxlovid and placebo recipients. Another important point is that post-treatment viral RNA rebound was not associated with the primary clinical outcome, which is hospitalization or death. So there was no association there. And also, very importantly, when we speak about viral RNA rebound, post-treatment RNA rebound was not associated with drug resistance. And we measured that by looking at the sequencing Paxlovid target, which is the MPRO protease. And ultimately, the clinical relevance of post-treatment increases in viral RNA following Paxlovid or placebo is still being looked at, and it's unknown at the point. I would also mention, in context, there was an FDA update, which is live on the FDA website, and CDC also has issued a Health Alert Network Health Advisory, which is available. Yeah, I'll pause there and hope I answered your question there.
All right, thank you. Definitely a lot more to learn about that, but I appreciate that. And even though I said that was your last question for right now, one has come in already and it's pertinent to what you've been discussing. So I'm going to ask one more and then we'll go to Shelley. So Shelley, get ready. So the question is that providers are telling patients they're not sick enough to receive Paxlovid, despite patients having 1+ risk factors according to the CDC guidelines. Should a provider be using a current symptom load as whether or not a patient needs Paxlovid treatment?
That's a great question, and the answer is definitely not. So again, thinking about who can be considered for treatment with any antiviral for that matter, is you don't want to wait for the patient to have very bad symptoms, which may mean at some point they may require hospitalization. And the whole purpose of antivirals that are being employed is to prevent that from happening. So the whole idea is to treat early enough so that we prevent the bad outcomes such as hospitalization, which obviously can worsen with ICU and mechanical ventilation and so on. And so there's obviously there's a relationship between symptom severity, but the key eligibility criteria is the risk, the high risk. So I encourage everyone to look at the conditions and criteria that place patients at high risk for progression to severe illness, and those are on CDC. Those are displayed on CDC, and there's a number of conditions there: heart conditions, chronic kidney disease, having been a smoker, obesity, over 25 body mass index, obviously pulmonary conditions, including asthma. So a long range of conditions. All in all, we think that about, I mean, and we've seen CDC numbers, about 50 to maybe even 60% of the US population is at high risk for progression to severe illness. Now, in terms of symptoms, for a patient, for an individual patient to be eligible under this emergency use authorization for treatment with Paxlovid, they need to have a positive test, be within 5 days of symptom onset, which obviously means being symptomatic, and have mild to moderate symptoms. And again, CDC, I won't go into all the details, but again, mild to moderate. And definitely, there's no wait and see. Somebody who is at high risk can have very mild symptoms one day and then progress very quickly to severe or critical disease. So again, somebody who's at mild to moderate symptoms, but at high risk is to be considered for treatment.
All right, great, thanks. And thank you to whomever asked that question. It was a great question. Okay, Shelley, so tell us, so you're in Canada, and pharmacists in Canada have been prescribing Paxlovid for some time. So can you tell us a little bit about the experience and even like approaching how patients are eligible?
Yeah, absolutely. Thanks for the question, Teresa. And first of all, again, echoing what Florin said, wanted to thank you for inviting me here. Super excited to see the FDA announcement last week and to see that our American colleagues are now able, and actually now a little bit ahead of us in terms of being able to prescribe sort of in all states, whereas in Canada it's still provincially regulated and legislated. So we actually did start back in April. The province of Quebec was the first province on April 1st on the planet, actually, to allow pharmacists to be able to prescribe for Paxlovid as an oral antiviral. And early data sort of indicated that 70%, even in that first month of gaining that authority, 70% of all Paxlovid prescriptions in Quebec were written by pharmacists. So that gives you an idea of how much they drove access and uptake. We don't have, unfortunately, we're still trying to get some more data on how things are going, you know, in terms of how much they are driving uptake, but certainly that data, I think something like an increase even in over 300 antivirals dispensed in Quebec since pharmacists were involved. So just, it gives you sort of an illustration of how key the pharmacy health hub is in really improving uptake and access to these important antivirals. And then since then, there were key pharmacies in several provinces that started to enable dispensing. So Quebec was the first province to start with prescribing. Weeks after that, about 9 or 10 of our provinces were having select pharmacies dispense. And so that was mostly an access to care issue as it is in the US. So in provinces where there was good centralized access to care, there was the ability to prescribe, they had just limited pharmacies dispensing, and then that started to broaden. And we saw in the most underserved provinces, and continue to see now, where we now have four provinces in Canada where pharmacists are allowed to prescribe. Those tend to be the provinces that don't have those centralized assessment centers, where you may have to drive for miles, where you don't have a primary care provider, where we really, really need to utilize those pharmacies who are truly the health hubs to provide access within a short window of time. So, I think it's really, all of the things that we say in terms of, reducing healthcare costs, improving access to medications, getting patients treated within the window, I think is really, really important, and some things that we've seen. So now, you'll start to see more prescribing. I would say that, I think Florin said this at the beginning, that awareness is really still a key issue. And I think that, and that'll sort of, I'll segue that into sort of the second half of the question you asked me, Teresa, in terms of, understanding eligibility criteria. When Paxlovid was first approved in Canada, eligibility criteria and access were somewhat restricted as well, because there were some supply challenges earlier on, which there aren't now. And it was really well communicated. So people knew what, you have to get this within a 5-day window, this is how sick you have to be, etc. But I think now people don't have an understanding. Like, they don't all know that you have to get this within 5 days. They don't all know what high risk means. So I think there's a really, really huge role for pharmacies and pharmacists to help with some of that awareness. In terms of assessment, you asked me about eligibility assessment in pharmacies, and so it varies again depending on the province. That's how Canada is. But in some provinces, there are standardized assessment forms that are provided by the government in a couple of provinces, and in others, the pharmacist will. It varies. Like they'll assess. They may do everything virtually. That's what happens in Quebec. The patient can self-test. Essentially, they can assess over the phone, they can prescribe, they can deliver. It's a completely touchless experience for that patient. You don't have a symptomatic patient walking into a pharmacy to get tested or to get access to their oral antiviral. So it varies, but there are, as I mentioned, I think just even a lack of awareness amongst providers now on, am I assessing this patient? Am I considering this patient for Paxlovid? It's a really important opportunity for pharmacy, and I think. At least in Canada, we're in a 7th wave now, and I anticipate that we may see an uptick of antivirals being prescribed, and so that awareness becomes even more important right now, where I'm seeing COVID personally everywhere I turn these days. So still don't understand the behavior of this virus completely, but there's a huge role for pharmacists.
Thank you, Shelley. I am going to go back to Florin for a question, but I'm going to come back and forth between you two. It is very interesting to hear the differences in the various provinces, and I just appreciate you sharing those experiences, and also the way that Canada has led the way, and we can learn from what you've done. Florin, I do have a question about obtaining medical history. Oh, I'm sorry. Let's talk about renal and hepatic function. So safety concerns around that. If we could start with that, please.
Yeah, and I think that relates with some of the provisions in the update. So, and that relates to hepatic and renal function. So, in a nutshell, Paxlovid is not recommended in patients with severe renal impairment, and that's an eGFR below 30 milliliters per minute, until more data is available. So we don't have data to identify the appropriate dosage for patients with severe renal impairment. We haven't determined the right dosage. Similarly, related to hepatic function, so no dosage adjustment is needed in patients with mild or moderate hepatic impairment, but we don't have pharmacokinetic or safety data regarding the use of nirmatrelvir or ritonavir in subjects with severe hepatic impairment, and that's Child-Pugh class C. So therefore, Paxlovid is not recommended for use in patients with severe hepatic impairment. Speaking about renal impairment, I need to add, because I think this is really important in practice, and there were some changes there that I'd like to highlight. That as everybody knows, the normal dose for Paxlovid is 300 milligrams of nirmatrelvir with 100 milligrams of ritonavir, and each carton contains 30 tablets in 5 daily dose blister cards. And so patients need to take 3 tablets, 2 nirmatrelvir, 1 ritonavir, twice a day, 1 in the morning and 1 dose in the evening. Now we have a second dose pack, which is 150 milligram nirmatrelvir and 100 milligram ritonavir. So 1 tablet nirmatrelvir, 1 tablet ritonavir, that can be used for patients with moderate renal impairment. Similarly, each carton contains contains 5 blisters, but in total, there's a total of 20 tablets in these blister cards. And no dosage adjustment is required for patients with mild renal impairment. So this dosage, some people call it the renal pack. It's 150 milligram, 100 milligram Paxlovid pack can be used for patients with moderate renal impairment. I'll also point that pharmacists can also order the pharmacist instruction sheet, which provides information on how to adjust the dosage of Paxlovid for patients with moderate renal impairment if that lower dose pack is not available. And before that pack was made available, which was a couple of months ago, we had a process where the 300, 100 milligram pack was shipped together with these instructions and with stickers. And these maybe already still be shipped. In any case, they can be ordered if pharmacists prefer that route of removing tablets, applying stickers on the blisters and on the carton, or, and I suggest this as a first go-to, if at all possible, order the 150 nirmatrelvir 100 milligram ritonavir dose pack. Over.
Okay. Thank you for that. Can you also talk about medical history, obtaining a medical history from patients, the importance of that, and specifically drug interactions that pharmacists need to be watching out for?
Yeah. So that's a very good question. So indeed, the medical history is needed for assessment of renal and hepatic function. Also, in terms of getting all the complete history for the patients, it's important as it relates to drug interaction. So, as I'm sure everybody knows, Paxlovid is nirmatrelvir with ritonavir. The purpose of ritonavir there is exactly to enhance the levels of basically the PK profile of nirmatrelvir and allow it to be effective at higher concentrations for a longer time. And ritonavir is an inhibitor of the cytochrome 3A and may increase plasma concentrations of other drugs that are primarily metabolized by the 3A cytochrome. And so co-administration of Paxlovid with drugs that are highly dependent on the cytochrome 3A4 clearance and for which elevated plasma concentrations may be associated with serious or life-threatening events is contraindicated. Also, co-administration with other cytochrome 3A substrates might require a dose adjustment or additional monitoring, and that's detailed in the Paxlovid fact sheet. There's table 1 in that fact sheet. And so I would encourage everybody to look at the list of clinically significant drug interactions, including contraindicated drugs, in section 7 of the Paxlovid fact sheet. An important note there, though, is that the drugs listed in the table are considered a guide and not considered a comprehensive list of all possible drugs that may interact with Paxlovid. And by the fact sheets, and FDA, by that encourages healthcare providers to consult other appropriate resources, such as the prescribing information for the interacting for the interacting drug, for comprehensive information on dosing or monitoring with concomitant use of strong cytochrome inhibitors. To help finding that information, what we've done, for example, when Paxlovid fact sheet referred another drug's fact sheet, we developed a resource that captures that information in the same place, which is available on pfizerpro.com. And if people visit that website, there's a medical website that can be accessed, and there's a drug interaction resource there. As additional resources, Pfizer also have pfizermedicalinformation.com, where included there is a tool, so it's a drug checker which is reliant on our fact sheet. And in addition to that, FDA developed a Paxlovid patient eligibility screening checklist tool for prescribers, which is available on the FDA website. And NIH also has Paxlovid guidelines, where included our drug interaction recommendations.
All right, thank you so much. So much information for us to take in, and I appreciate all those resources. So Shelley, I'm going to just ask you a couple of last questions, and we're going to move on to Mike and to Megan. So if you could just talk a little bit about your experiences with assessing patients and collecting that data about their renal and hepatic function and drug interactions, and then how you're, what your pharmacists have done for documentation too. And then I guess there is a question for you to share a screening form too at some point. But if you'll just talk about those things, please.
Sure, absolutely. I just want to reiterate what Florin said in terms of there are a lot of resources out there, and we've talked to our, physicians and pharmacists in Canada about there's value in redundancy because we're still learning a lot about, documented drug interactions and potential drug interactions, and what we know about ritonavir as an old HIV drug and all of the drug interactions that it had. As one of our very public, pretty famous infectious disease physician says in Canada, the best resource on the planet for drug interactions is your pharmacist. So I will start by saying that, but I think in Canada, pharmacists in some provinces, again, it does vary by province, have centralized medical records that they can access. So they may actually have full access to lab data and prescription data in some provinces, and that makes it really easy for them to check an eGFR, to check for renal function, to calculate a creatinine clearance. In other provinces, it may be a little bit more difficult, and they have to seek out that information either from the patient or the prescribers. So we really encourage prescribers to put as much as they can on that prescription. So whether it's a standardized prescription form that already has an eGFR on it, or the prescriber just writes it down, it's really, really important to be redundant and not just assume that, each provider has access to all the information, but just provide it as much as you can, ahead of time, because you only have a 5-day window. I think a really important thing, to let US pharmacists know is that in Canada, we can then adapt dosages as well. So whether it's the Paxlovid itself or whether it's one of the interacting drugs that the pharmacist has identified, they're not only the best at identifying those drugs or validating the drug interaction, but they can help mitigate and manage that so that the patient can potentially still get the Paxlovid but have their interacting drugs adjusted. So whether it's adjusting their DOAC or their calcium channel blocker or whatever else there is, all within a really important circle of communication, obviously, but leveraging what the pharmacists can do. And we've reminded our physician prescribers in Canada that pharmacists can help with that dose adjustment, so we're not waiting again another day to figure out what to do with that patient when you only have maybe you're counting down the clock. In terms of your question about documentation and best practices, again, as I said, there's always a real key importance to document any of those. If you've made medication changes as a pharmacist, whether you're dispensing or prescribing, making sure that everybody in the circle of care has that information, documenting it in your own health record in the pharmacy is important. But even from the prescribing standpoint, in some provinces, there are standardized prescribing forms that just lay out everything, tick off the criteria, what's the creatinine clearance, and I can certainly share those that are publicly available. I'm happy to share them after the webinar, so folks can see those, both on the assessment and the prescribing. But really, really important just to make sure that documentation happens, whether it's standardized and is really, becomes part of the workflow. So there's some examples that I'm happy to share after the discussion, but really important to document well, absolutely.
Thank you, Shelley. Yeah, the time is definitely flying by today, so I appreciate you sharing that. I love the collaborative nature too that you're talking about working with the physicians, and I know that that's a really big part of this. So thank you so much. All right, so let's move to Mike. Let's talk. We're going to switch gears a little bit and talk about reimbursement. So the lack of reimbursement, especially for the dispensing fee, is definitely a barrier. And now as pharmacists are going to be more involved in the professional side of assessment, that's certainly a concern, I know, for many. So can you talk about what APHA is doing to address that?
Sure, yeah. Well, thanks, Teresa. And I don't know if we can advance the slide to the test and treat slide. Can we do that? Thank you. Thanks very much. Well, right after we successfully achieved authorization to prescribe Paxlovid, albeit with some guardrails, the immediate next question for our members as well is CMS or Medicare and other payers actually going to pay me for the required services necessary for pharmacist prescribing? Our immediate response to CMS, as you can see on this slide, after receiving FDA's revised EUA, was this is how we want it to work. And setting up a reimbursement pathway, it's really important to separate out the clinical services for pharmacists to prescribe Paxlovid from the dispensing fees that you mentioned for these medications, which most PBMs have already ridiculously set at less than $1 based on CMS's current guidance that only encourages plans to provide enhanced dispensing fees, which the majority of PBMs simply are not providing. And we know these dispensing fees are unacceptable and a disincentive to pharmacies to even stock these medications due to the lack of coverage for the required patient safety checks that can take anywhere from 15 to 30 minutes of a pharmacist's time, and that's an issue that also must be addressed. But as you can see from the slide, and as we've told CMS, APHA's ideal state for payment for test to treat services, which are listed in blue on the slide, would be paid by Medicare under Part B for medical services, as in B as in blue, for pharmacists to be paid just as they are for every other prescriber. And the dispensing fee, where reimbursement also still needs to be fixed, is listed in black under Part D, as in dog on this slide. And CMS has also released, even more recently, new guidance for some additional payments to incentivize Paxlovid prescribing in hospitals, but no updates yet on pharmacist prescribing. Okay, now let's move on to the next slide if we can. There we go. Thank you. And I'm going to go ahead and put this in the chat, our Take Action link that we're providing. You know, we just finished discussing what we want from CMS and other payers, and this slide is kind of where we're at, right? So we know right now there's no adequate payment mechanism for all of the necessary clinical services for pharmacists to prescribe and dispense Paxlovid. So we're continuing our multi-pronged approach to address this issue. As Lisa said at the beginning, you know, advocacy has gotten us this far. We really need your help to bring it across the finish line. You can see in the action link, if you click on there, it's our easy, it's pre-written, editable as well, so you can add your own stories in there as well. Advocacy alert to alert your elected officials to contact CMS or Medicare to identify a payment pathway to reimburse pharmacists for all the required services to prescribe Paxlovid. I'm also going to try and add in another link as well, just so folks can see the letter that we sent to the president, to President Biden at this point. And this letter actually told the administration that, you know, obviously we don't think that this administration would have taken all the pro-pharmacist steps that they have. So first, authorizing our members to prescribe COVID-19 therapeutics during the public health emergency under the 9th Amendment to the PrEP Act Declaration that Elisa mentioned at the beginning. FDA, you know, obviously wouldn't have taken all the time to amend the EUA to allow pharmacists to prescribe. But as always, you know, we know that your voice, you know, makes us as strong as we are. We certainly hope that you'll take a few minutes today to tell your elected officials to make sure that CMS pays pharmacists, you know, what is necessary to prescribe this life-saving medication. And I'll stop there and turn it back over to you, Teresa, and look forward to future questions.
All right, thank you very much. Shelley, I might come back to you in a minute for reimbursement in Canada, but I think I'm going to move on to give Megan a chance to talk, and then we'll see how we're doing with time. Is that fair? All right. And Mike, thanks for sharing that about advocacy, because I've definitely had a lot of people say, what can I do? How can I make a difference with this? And it is really important for our members and our audience to understand that we do need them. We need their voice to amplify everything that we've been doing on their behalf. So I really appreciate you sharing that opportunity. All right. So Megan, thank you for being with us today. And there are some questions just about supply of Paxlovid. I guess in some areas it's been limited in the US. So there's questions about, you know, is it going to be more available now that pharmacists are able to prescribe? And then we had a question in the chat that hopefully you might have seen too that was related, maybe not, but it was about, you know, if we can't get it, is there any provision to drop ship or get it a little faster if for some reason a pharmacy hasn't had access and needs something a little more quickly? I think if I understood it, I read it correctly, that's what the question was. So, but if you could just talk about access right now, thank you.
Yeah, no, thank you. Thank you so much. And thank you for the invitation. So a lot to cover, and I'll try to be brief because I know we're running out of time, but you know, supply is not constrained for either of the oral antivirals right now. So I do want to make that message loud and clear. We were in a supply constrained situation previously this year, and unfortunately, you know, coincided with the Omicron surge. But right now, that is not the case, and we currently have product placed, you know, at over 40,000 locations nationwide. The latest analysis shows that 88%, actually more than 88% of the population is within 5 miles of a site that can dispense the oral antiviral. So it's really, you know, we're working very hard to make sure that the product gets placed throughout the country. Of course, that doesn't mean that there can't still be gaps, and then we do always try to work to fill those gaps. So to to answer the specific questions, right now we do continue to distribute direct to our federal pharmacy partners, so that we have 20 currently federal pharmacy partners, and we do a direct distribution to those pharmacy partners. But we also do direct distribution to our jurisdictional partners, so that's states, territories, and to federal entities. So for pharmacies that are not part of that federal pharmacy network, they can either come to us to have that discussion of whether that's an appropriate mechanism for them if they're part of a larger network of pharmacies. But the easiest way for a pharmacy to get access to supply is to talk to their state. So to reach out to the state health department to get registered as an HPOP, that's our ordering portal, to get registered as a user. And then, we can definitely operationalize getting supply to you on a regular basis. We do not want, there to be anyone who is willing to be part of this program. We appreciate everything that you as pharmacists and as pharmacies are doing so far to educate the public, to get people the drugs that they need when they need them and place them where they need to be. So supply should not be the obstacle, and please reach out to us if you're having trouble. I do just want to take one quick moment to sort of talk about the Test to Treat program, just so everybody's on the same page. The Test to Treat program is separate from our total oral antiviral program, or even separate from our total COVID-19 therapeutics program, right, which goes even beyond oral antivirals. The Test to Treat program, again, is very important, right, and was stood up to try to, answer the question, well, if I don't have a healthcare provider, right, how do I get that prescription? But, it's less than 10% of the total sites that we have currently active dispensing the oral antiviral. So just want to keep that in mind. And when we look at the overall analysis of where our total program sites are, they are located in the right places, right? They are in the high vulnerable zip codes. And so there's still a barrier access to access, right, in those populations. And, these are for factors that you guys are all on your radar, but just want to make that plea that we still think there's a lot of and awareness to raise the comfort level overall, but also specific to those areas, so that they are really both from a public perception perspective and also from the comfort level of a provider to write those prescriptions. We think that's really key. So appreciate all the collaboration and work you guys have done so far, and just ask that you please continue that important work.
Thank you, Megan, for the clarification on the Test to Treat program, and also for the clarification about receiving the Paxlovid and oral antivirals through the state. I recently had a pharmacy in my state reach out and ask, and I didn't even realize that was something that was an option. I thought they were only available through the federal retail program. So yes, if you could just contact your local state health department, then you can find out more information. And maybe that's something we can get for resources that we can put. I know APHA is furiously posting resources for all of you in the chat today. So hopefully we can get some links for you to local state health departments. Megan, it looks like another question.
Sorry, I saw one other question that I just want to address about where is the product. We have 2 locator tools. I just want to make sure everybody knows, and maybe you could pass those on resources. We have a Test to Treat locator, right, which we call the Test to Treat locator, but actually has the entire universe of where the product lives, even if it's not a Test to Treat site. And that's specific, that's a public-facing locator tool. And that includes both of the oral antiviral products again, and then designates whether a particular site is part of the Test to Treat program or isn't, right? So there's a lot going on there, so please use that tool. Then we have a separate tool for providers, which is the COVID-19 therapeutics tool, locator tool, and that's the whole universe of our therapeutics portfolio. So happy to pass on those resources to you so you can pass it out into this larger audience.
All right, Megan, and there's one other question for you. So are the requirements for the non-federal pharmacy network providers the same, so I guess through the state, the same as the requirements for the federal network providers? So is there any difference that you know of between getting it from one source or the other?
That's a great question, and thank you. So no, there is difference in the requirements, yes, right? So if If you're not part of that federal pharmacy partner, which we really sort of, there's criteria there around, how many states you're in, right? If you're cross states, you're more of a national presence, how many providers that are within your network, that kind of thing. Anyone else, right, who doesn't fit into that category should be eligible. As long as you are a licensed provider, you are eligible to get it through your state. And if you're having difficulties, right, you can always come to us directly, right, just to highlight that difficulty, and we can try to help you navigate that process. So the best resource to reach out to us is COVID-19 therapeutics at hhs.gov. I'm going to double check.
So a lot of questions are starting to come in. I think we want to go a few minutes over if everybody's available to do that. Are you all available to stay for a couple of minutes? No. All right. So there is a question that just came in about pausing statin therapy while patients are on Paxlovid, and how do we approach patients with statins? So Lauren or Shelley, either of you can take that if you want.
Yeah, Florian, I can take that quickly. So first of all, to say that there's a distinction between statins. So there's a different approach to rosuvastatin and atorvastatin versus lovastatin and simvastatin. So these two that I mentioned last, lovastatin and simvastatin, are contraindicated due to potential for myopathy, including rhabdomyolysis, and they can be discontinued if, obviously, following the risk-benefit consideration. There is a recommendation in the fact sheet that discontinuation of lovastatin and simvastatin should be 12 hours prior to initiation of Paxlovid during the 5 days of Paxlovid treatment, and then for 5 days after completing Paxlovid. Versus atorvastatin and rosuvastatin, which are under other drugs that can consider adverse events, but they're not contraindicated. So the recommendation there is to consider temporary discontinuation, but they do not need to be held prior to or after completing Paxlovid. And again, importantly, is these two that I mentioned last, they are not on the contraindicated list.
All right, great. Thank you very much. Shelley, did you want to add anything about experience?
Maybe I'll just add, and Teresa, you could add too, as a pharmacist. And statins have really long half-lives, right? So I think the idea of holding a statin for a few days, this is a relatively short course of treatment, and in most patients is perfectly okay. So it's one of the drug classes that I personally don't worry about as much, because we know that even some people, will take their statins, just 2 or 3 times a week, particularly as Lauren mentioned, with some of the longer acting statins, holding them for a few days is not really going to have any critical ramifications. So that's something that I'll often tell physicians and pharmacists when they ask me that. There are people that have different practices, and so there's some professional discretion in there, but no real big concerns.
All right, thanks. And Shelley, let me come back to you. There was a question just about what if you can't really obtain a great medical history on a patient? It was exciting to hear about possible EHR, HIE access in Canada, but what has the experience been with you? And then I can kind of try to talk about that a little bit from our experience as well.
Yeah, sure. I mean, it would be, as pharmacists, we want to have as much information as possible. So if you don't have information from a health record, which is still a major gap in many areas of Canada, I was laughing because somebody said, so an attendee said she wanted to move to Canada. So don't move it in January, but it's not have everything fixed. But what I say to my prescriber colleagues is communication is so key. If you're thinking about prescribing, or if you're working with a pharmacist, put as much on, as I said before, put as much on the prescription as possible. Be available to that pharmacist if they need to call you, so that we can get that patient treated. Put your phone number at the weekend, they're not gonna be able to reach the office. Stay open. That 5-day window is a 5-day window. So I think asking the patient for information, but remembering that there are several people in that circle of care that need to really be transparent with the patient in the middle of getting all the information in a very timely fashion. That's really the best way to do it, I think.
All right, that's great. I do want to just thank Megan. She's going to have to leave, but thank you so much for your great information and for the resources you've given us. We really are thankful that you were able to join us today.
No, and I thank you really for the opportunity, and happy to continue the conversation in other forums. And we're always available by email or other mechanisms. So thanks, everyone.
All right. And then back to obtaining medical information. I think, I do appreciate what you said, Shelley, about just the timeliness and how important this is. And I think many of us have been experiencing that already. And for pharmacists that are concerned this is going to take more time, I think in many cases it's taken a lot of time right now. So just continuing to be persistent if we can reach out to the doctors to prescribers to get more information. For lab data, sometimes patients have their lab data, they forget, they have it on an app on their phone. So you might be able to ask that way, and that's one of the things that we're planning to do. And then I think you heard a little bit already, but I think that our associations are going to continue to advocate too in the U.S. for access to HIEs and being able to obtain some of that information that way. So hopefully more to come from the APhA and advocacy perspective. All right, the questions are really starting to fly in, so let me see what I can do. I think, Florin, this one's going to come to you. If a patient does not qualify for Paxlovid due to hepatic or renal issues, should the pharmacist share that information with the care team? And is there another way to recommend another treatment, such as a monoclonal antibody? So Florin or Shelley, either of you.
Yeah, I think I'll leave Shelley to respond, because it is about other drugs that people may be eligible for. Yep.
Okay.
Sure, I don't mind taking that generally. So, I mean, I think, yeah, it's, again, it's really, really important to let the pharmacist know, because not only is the pharmacist going to help manage the treatment for this patient, but pharmacists in communities in Canada, and I'm sure in the US, because of their accessibility and, someone can really, have that touch point with their pharmacy team, they can also be a good referral source to other points of care. So if there has to be a quick communication to get that patient a remdesivir or a MAB or something like that, and there needs to be a referral or a connection back to a primary care provider or a specialist, definitely leverage the pharmacist and the touch points that they have to be able to make the right referrals in the community within a short period of time, because some of those therapies are community-based, and patients may be candidates for other therapies if they're not for Paxlovid. Again, it's just about keeping those lines of communication open.
All right, great. And let me ask you one more, Shelley. So your experience, where would you say pharmacists have dispensed Paxlovid the most as far as practice settings? So ambulatory care chains, independents, do you have any idea based on the surveys you've done?
Well, unfortunately, we don't have hard data on where or what sectors of pharmacy have been dispensing the most. I think we haven't seen. I think initially we saw some uptake, and just from some anecdotal sort of feedback that I've received from our members, I still think there's a huge lack of awareness issue, and I think that crosses everywhere. So I think, again, it'll be interesting to see here in Canada and maybe in the US with clearly this virus not going away and with more COVID circulating right now with this 7th wave that we're having, what happens? I think that the role of public awareness is everyone's role in terms of understand this, have you tested? To take it back to sort of, if you don't mind, in terms of assessment, it takes a long time, as others have said, to sit down and figure out whether that patient is a candidate, but then also to go through a complex medical history and navigate all of those drug interactions. So investing in that assessment time so that patients don't get left out, eligible patients, is key. And so back to what Mike said, I just want to say it is hugely important to value the time that it takes. Infectious disease doctors have told me with that first patient, it takes me 45 minutes. So this is not like an ACE inhibitor. This is a complex medication, and pharmacists are so well placed, especially if they know that patient's medication history, or they get all their prescriptions filled there, to do that assessment so that patient doesn't get left out. So I think the lack of awareness is still a challenge. And I think understanding what the criteria are now that there's a very healthy supply of oral antiviral in the community, it's not an issue of not being able to get the drug. And we want people to do well and stay out of the hospital, as the evidence shows they can with this medication.
Great. All right. So I'm going to ask you one more question, Shelley, and then we're going to move to wrap up. So we're going to come back to the reimbursement issue. And the reason is that you just talked about the time. And I think that that's so important because it does take a lot of time to do this well. So can you just talk a little bit, I know it's a little bit different in each province, but how pharmacists are being paid. And if you could, just talk a little bit about that. I know that we have restrictions about what we can say about payment, but just how pharmacists are being paid, like for their assessment time or the dispensing or something along those lines. Thanks.
Yeah, I'll talk in generalities. I'm not sharing specific numbers, and some of this is publicly available in Canada because it's public funding from government. But again, totally agree with you, Teresa. What we say to governments when we advocate, and Michael is bang on, like we really need to think about the patient at the center and investing the time that it takes to make sure that we're caring for that patient appropriately and remunerating appropriately for that. It's not a bad word. So I think for us, it does vary. So there are some provinces where it's a dispensing fee or a dispensing top up. And maybe the top up is not enough. And in some provinces where they're prescribing, there is an assessment fee. Assessment is key, even if you don't end up prescribing. We talk about this. You're assessing a patient, you need to be remunerated for that. Even if it doesn't end up with a prescription, you're still taking that time. The follow-up fees, I talked about this a little bit in our pre-call, but in one of our provinces, pharmacists are actually remunerated for post-dispense surveillance to check on those patients, check on adverse events, because if people are getting diarrhea and they stop and no one talks to them about, see if you can manage this for one more day, they may stop treatment. So understanding what real world evidence is like and investing in that is also important. I think for us, advocacy again is huge because we always say, being able to access Paxlovid from A to Z from a test shouldn't depend on your zip code or your postal code or where you live. It should be the same across the country. So we've advocated, you have this, we've advocated for this since April to say across the country, pharmacy should be an access point for assess, test, prescribe, treat, deliver if you need to, because there's no other channel where that's possible. So continue to do that. And I love what you put up on your slide, because I think advocacy is everyone's job. And so we need everyone to, at the grassroots, to have these conversations with and tell the stories, because stories mean everything. Have the conversations with your patients or with your elected officials and talk about the value in that.
All right, great. Thank you so much for that. And you're absolutely right that we need to be doing whatever we can to advocate for that and for patients to have that access. So, and it's not a bad word to talk about being appropriately paid. All right, so I think there's probably a lot of other questions, but I do think that we're going to move to wrap up. This Pulse on Policy series is once a month on the second Thursday, and we had planned a different topic for today, but then this came up. So I have a feeling this one might be ongoing. I suspect we could even talk about this some more next month. We'll see how things are going, but there is a lot to talk about and a lot of questions. So if we didn't get to your question today, we apologize. We are going to be working to send out resources after the program. So I want to make sure I let you know that. So watch for that follow-up email with all of those resources. And I definitely want to thank our speakers today, all of our guests, for just such great information. I think we do have a few slides to run through. First of all, we do have a test to treat for Paxlovid page on the pharmacist.com site. So that is the link right there. And just want to make sure you know that that's the place we're going to be putting resources as we have them. Hopefully for all of you, APHA has been a tremendous area of accessing resources for COVID related. We've had so many that are there, and you'll find those on our pharmacist.com page as well. So education, we do have access to continuing education as well. That is available. So you can find that on the links that you will see afterwards. So there's one on oral antivirals, and then specifically one on Paxlovid. And we do want to at least mention that the FDA has approved Novavax. So there's some information there, and APHA will be providing information as soon as we have more to give you, and be updating all of those resources that we just mentioned on our vaccines page, as you can see there. So as that information comes out, but that is really breaking news for today. We want to make sure that each of you are aware of that. And we've talked a lot about advocacy, and like I mentioned, APHA has such a great team that does amazing advocacy. So for those of you that are members, and we hope you'll consider that, of the American Pharmacists Association, every 2 weeks you will get what we like to call the reg update in your email, and it tells you so much information about everything that APHA is advocating for. And it also gives you those actionable opportunities to have a voice and be able to make an impact. So we encourage you to join, and also to be acting upon these emails as they come to you. So, as I mentioned, I think we perhaps have non-members on our webinar today, and we hope that you will consider being a member of APHA. I'm a little biased, but I like to think that membership is incredibly valuable, and hopefully you've heard that today from all the things that APHA is doing, and this is just a snippet of everything that's happening at the American Pharmacists Association. So we hope you'll consider joining, pharmacist.com/join. And I already mentioned the forum for next month, sorry, not doing it quite next week. So the second Thursday, August 11th, it will go back to our normal time, which is 1 to 2 p.m. Eastern. You can go ahead and register now if you'd like. As I mentioned, we don't quite know the policy topic. We try to be flexible about that depending what's happening and what we need to be talking about. And with that, I think that we will conclude today. So I want to thank Team APHA behind the scenes for all the work that you're doing. Thank you to Anne and Meg and Bridget and others that are back there helping out. And a special thanks to our panelists today for just such valuable information. And good luck to all you pharmacists out there as you start prescribing. We're very excited, and we're here to support you. Have a great day.
Thank you.
Bye-bye.